Hey everybody, it's Dr. Wood, and today we're going to be talking about some of our respiratory disorders. And so again, another really common thing people will be presenting to the hospital, the ERs, or urgent cares for, they can be complaining of things like chest pain. And normally you think of chest pain, you think like a myocardial infarction, heart attack, when it could just be related to issues of the respiratory tract being, sore, irritated, inflamed, anything like that. Certainly difficulty breathing, which we can also call as dyspnea, acute or chronic cough, dysphonia, where they actually have changes in their voice or it hurts to speak, fatigue, fever, chills, hemoptysis, where they actually are coughing up blood, or epistaxis, where they actually have a nosebleed occurring there. Any of these things could be related back to some of the respiratory conditions that we'll talk about today. And in terms of the medications, common things you might find with these medications include things like dry mouth, tachycardia, or kind of a rapid heart rate, some nervousness, or sort of just kind of being on edge a little bit can be related to these medications there that can lead to lack of sleep potentially. Things like stomatitis or sores in the mouth, drowsiness, hypotension, and decreased coordination. We'll talk about these individually as we get into the specific drug classes. Now, first off, the first drug that we deal with in terms of respiratory issues are going to be oxygen, right? Oxygen is a drug just like anything else. And so typically what we'll do is administer this either via a nasal cannula, which you can see illustrated right here. Basically, there's two prongs that will put oxygen kind of going up into the nose there that will supply some extra oxygen for the patient there, usually ordered in liters per minute. So you may say start 2 liters per minute or 4 liters per minute via nasal cannula. Or in some cases, you may need to use something a little bit more labor intensive, something to make sure the patient's getting more oxygen in. And so you can use a mask here that basically prevents all that oxygen from the patient basically from breathing out, and it will go into a reservoir that's down here. It's called a non-rebreather, and basically the O2 will reside here to make sure the patient's inhaling sort of a more concentrated form of the O2 there. Really important point here is you never want to make sure you mix oxygen with open flames because it is quite combustible. I saw one patient that had a long-term COPD, was a long-time smoker, and basically was trying to cook some food on a gas stove with his oxygen on and smoking at the same time. And needless to say, it was a sort of explosive combination, and the patient ultimately died from the burns that he suffered from that combination. It's really, really important. Don't mix oxygen with any sort of open flames. So things that can occur, let's talk about allergic rhinitis here in terms of an upper respiratory tract condition here. Very, very common allergic disorder for patients to be presenting with. Come in with sneezing and possibly slight nosebleeds and runny nose, all these things related to their allergic rhinitis. And a lot of this is related to inflammation, and a lot of it tends to be related to histamine, which is one of the major drug targets we're going to be focusing on here. Basically, it causes a lot of the itchiness, redness, and also vasodilation that occurs, that it leads to a lot of that stuffiness and whatnot. Basically, as the vessels, when they get more dilated, they tend to get more leaky, and so fluid likes to come out, and that causes a lot of that edema or stuffiness that happens there. And so it can occur with a number of different reasons. Could be environmental, could be due to medications, it could be due to lots of different things that could potentially trigger off a case of allergic rhinitis there. And so a couple of different drugs we're going to use here include things like antihistamines, some decongestants, and then some nasal preparations specifically that can be used to treat these nasal conditions. So in terms of antihistamines, basically, we've talked about these in the GI section before. There's primarily what you're going to find is your H1 receptors, and then there's H2. H2 is going to be more related to GI effects, as we saw there. So things like ranitidine, famotidine, things like that are going to be blocking your H2 receptors. For allergy, this is mainly going to be your H1 that we're talking about here. Okay, so basically by blocking those H1 receptors, they're going to be able to decrease a lot of the inflammation that comes about from activation with histamine. So you can use this for things like coughs and colds, for motion sickness. I know we talked about that before in the GI section in terms of antiemetics. They're useful for all of that. Now, they're not really going to be great for congestion because they don't really do anything necessary for all that stuffiness that occurs there, but they can be really good to help decrease inflammation and can help to kind of start that process off. Now, the big thing you're going to find here is that many of them can cause a lot of dizziness and drowsiness. A lot of that has to do with their effects on the brain specifically, and we'll talk about those in a minute. But you can get around that by using what we call second-generation agents. And so first generation is typically going to cause a lot more drowsiness and dizziness. Second-gen agents don't do that. That's mainly because they cannot get into the brain. Basically, they are unable to cross over due to their actual physiochemical sort of properties there. So the first generations, you've probably heard of a lot of these, which can include things like diphenhydramine or Benadryl, there's chlorpheniramine, doxylamine. Now, we mentioned here that sleepiness and basically drowsiness is going to be a very common side effect from the first generation antihistamines, and that's specifically what it's being marketed for, is to help with sleep. So Unisom is used as an over-the-counter sleep remedy, and basically that's what we're using it for, using a side effect of the drug for its therapeutic purpose there. Other ones include hydroxyzine, meclizine, and dimenhydrinase. A lot of over-the-counter varieties here. And then you'll have the second generation agents, which this will cause basically no sedation, mainly because it cannot actually get up into the brain to cause those effects there. So no sedation, and includes loratadine, fexofenadine, and cetirizine. Occasionally you'll find some patient that will say, oh, I actually still get sleepy with something like Zyrtec, but for the most part, most patients will not have that issue there, which is important because if you have someone who, say, for instance, is a truck driver and they need to have their wits about them to be driving all day long, maybe a first generation agent isn't great for them. Maybe that you want to recommend a second generation drug. In terms of decongestants, these are mainly going to be vasoconstrictive agents here. They're going to cause the blood vessels to shrink down, and that will help to decrease a lot of that edema and that fluid leakage there that will help to shrink down the swollen mucous membranes. We have a couple different varieties here. There's nasal and oral preparations, and I'll talk about those in a moment here. But because they are stimulants that cause vasoconstriction, they also cause a host of other side effects as well. Things like tachycardia, they cause hypertension. This is actually a really big thing that you want to avoid using in patients with uncontrolled hypertension. Can cause restlessness, insomnia, especially if you use it too close to bedtime because they are stimulants. And so you really be careful using this in patients with heart disease, glaucoma, prostate cancer, anything like that. Basically, they need to be checking in with their healthcare providers prior to starting use of any of these OTC decongestants. Now, an important thing to note here, especially with a product called Afrin, which is the brand name, or oxymetazoline is the generic, you don't want to use this more than 5 days. And the reason for that is because you'll find that it's really effective for dealing with that nasal congestion, but they kind of get physically habituated to it, meaning that they have to have the drug around, otherwise they get what they call really bad rebound congestion, right? They call it rhinitis medicamentosa is the technical name for it, but they can be pretty bad, and if they get to this point, they'll have to go back on the drug and then gently titrate themselves down. So we don't really like it from that standpoint. Now, the nasal decongestants like Afrin work pretty rapidly to help with symptoms. However, some patients don't really like nasal sprays a whole lot, so it just depends on what they like to use. Oral decongestants tend to work a little bit more slowly, so maybe in the course of, say, an hour or two. And then you'll frequently find that decongestants are going to be used with antihistamines. So, for instance, if you ever see something like Allegra D, or anytime you see a D on something, that usually stands for decongestant, and that means it will include one of these agents here that we'll talk about in just a moment. So some of the common decongestants include things like phenylephrine and pseudoephedrine, and then you'll have the nasal spray oxymetazoline or Afrin, and this is the one that you don't want to use more than 5 days, so not for more than 5 days. Okay. One thing to note here is that pseudoephedrine is sort of notorious because the government decided to crack down on its availability, mainly because it could be used to make methamphetamines. And so because of that, that's why you have to give your driver's license, and you can only buy so much during a month because of the ability for people to make methamphetamines out of things like pseudoephedrine. And so and it's behind the counters at your CVS or Walgreens. And so what they did instead, the drug manufacturers, they made a product that contains phenylephrine instead, which cannot be used to make methamphetamine. But unfortunately, and you'll always know it has phenylephrine because it says PE on there, this does not work nearly as well. And so I'll have patients that say, man, that Sudafed just doesn't work for me anymore. It's because they're taking the one that has phenylephrine in it. So tell them to go to get the product that's behind the counter from the pharmacist or from whoever, and that's going to work a whole lot better for them. Some other agents you can find from the nasal standpoint include drug, it's called a mast cell stabilizer called Cromolyn. Basically, it prevents release of histamine, and this is only good for prevention, right? So all these agents here are good for preventing symptoms. They're not going to be good for actual treatment of symptoms as they already occur there, okay? So there's a mast cell stabilizer. There's glucocorticoids that you can use locally. So instead of working systemically, as you see there. We'll have ones that are just applied within the nose, so things like beclomethasone, fluticasone, mometasone are all there. Just be aware, nasal stinging and burning can occur with topical use of these products here. Occasionally you can see nosebleeds or epistaxis, but that is one thing just to see in some patients. Pretty rare, but just let them know that's normal if that does occur there. Other things to note in terms of its use is to make sure you don't apply the drug directly to the nasal mucosa or the actual bottle itself, and to make sure you clean it up after every use. Otherwise, it does get a little grody, and it could potentially spread infection around. Especially, you don't want to share these agents here, even though you may think you're in the same family, no big deal, but that can spread infection. Now, with combination products, you're frequently going to find that you'll have, especially cough and cold preparations will contain, several different drugs there. So, for instance, you may have something that has, say, for instance, diphenhydramine. You may have acetaminophen in there, and then you may have something like phenylephrine. The patients don't always need all these combinations here, so it's important just to give them the medications they need for whatever symptoms they're specifically having, so that way they can limit total drug exposure. And then the other thing as well is that some of these products, especially things like NyQuil, tend to contain alcohol, and this is to put the drug actually into solution. It's actually to help as an actual solubilizer, but what you can find is that it can cause drowsiness in and of itself, so you do want to be careful with that. So not only can you have drowsiness from the alcohol, but also from the first generation antihistamine, and that can lead to some synergistic issues. For coughing, basically, we cough for several reasons, mainly just to get rid of foreign matter, or we can clear our airways. And so cough can either come as dry or productive. Dry basically means that it is not producing any sort of mucus or anything like that. Productive is more seen with infectious causes, infectious etiologies, where they'll produce a lot of phlegm and mucus and sputum and all that good stuff during those coughs there. And again, depending on how your patients are presenting, you may ask them, hey, what does your cough look like? What does the actual mucus look like? Is it yellow? Is it green? That could be indicating infection. Is it pink or blood tinged? That could give you signs of other things happening there as well. And we want to deal with prolonged coughing because it can cause hemoptysis, cause spasms there. And so basically what we can do is give medications that help to either suppress how frequently they're coughing or just the intensity of the coughings in and of themselves. Ideally, though, you want to fix the underlying cause and deal with the infection, deal with whatever's actually causing the cough in the first place. They kind of fall into two different categories here, our antitussives or anti-cough medications, opioid and non-opioid. Basically, the ones that are opioid-based contain hydrocodone, so they can be abused, and they are considered to be a controlled substance. So they are a C2 medication, so it's under pretty tight control there. And again, be wary because it will cause significant sedation there. So some brand names you'll find it under includes Hycodan and Tussionex. And then the main non-opioid one we have there is called Robitussin, or dextromethorphan. And interestingly, dextromethorphan is actually a derivative of an opioid, but it doesn't cause any opioid effects in your patients there. And so this one's going to be seen over the counter quite frequently. So most of you have probably taken this at some point or another. Also good to note that just like how hydrocodone can be abused for its pain relieving effects and euphoria causing effects, dextromethorphan can also be abused by, especially I see this more often in teenagers and adolescents, mainly because it's easy to access, but they'll have what they call robotripping, or basically patients will take way too much dextromethorphan. So the robo coming from Robitussin, and then the tripping aspect from the hallucinations and euphoria and all of that they'll encounter from that. So if you ever hear that term, that is usually someone who's abusing dextromethorphan, taking very high doses in order to achieve a high from that. So in terms of patient education, make sure that patients are having a productive cough. If they are producing a lot of phlegm, especially if it looks infected, you may not want to use an over-the-counter cough product because you usually want them to get rid of that. You don't want them to just hang on to that mucus persistently because it may be harder to clear that infection, right? And typically if you have effects that are going on for a pretty prolonged period of time, like 10 days, you probably want them to go in to get checked out because it could be something else you may want to treat there. Obviously avoid any kind of irritants. And then, if you have patients who are having cough, especially due to a sore throat, things like chewing gum, drinking water, or using like hard candies can sometimes actually help out with that. So it's something you can use as an adjunct to the OTC stuff. Some other things we can do for a lot of mucus production in the lower respiratory tract include expectorants, which actually will help to make the cough more productive, that will actually stimulate secretions to try to get rid of some of that junk down there in the lungs. This can include things like guaifenesin or Mucinex. Basically will hydrate the the sputum, the actual mucus itself, and will allow for it to clear a little bit easier. Sometimes patients will get dehydrated, and all that mucus in the bottom of the lungs just kind of gets very desiccated and very hard to clear. So by using something like guaifenesin and drinking with plenty of water, they clear it a lot easier. In some cases, patients have like really thick, tenacious sort of mucus, especially if they have something like cystic fibrosis, which is a genetic condition. They can use what we call a mucolytic, and it actually will help to break down the proteins in the mucus in order to allow it to be easier to clear. So we have drugs like Dornase alpha, which is pulmozyme. You can even use things like hypertonic sodium chloride, like 7% saline, and then things like acetylcysteine or mucomist. All of these can be used to help break down the mucus, make it easier for patients to cough up and clear. Now, looking at some things we can use for chronic conditions of the lower respiratory tract, we're mainly going to be focusing on asthma and COPD. You're going to be basically finding if someone is dealing with acute bronchoconstriction or acute shortness of breath related to a smooth muscle constriction in the lungs, we're mainly going to be focusing on our beta-2 agonists. And I'll talk about the different drugs in this category as well, but this is basically your rescue inhalers. This is what's going to be used most commonly. We also have some long-acting formulations of a beta-2 agonist, things like salmeterol, but you'll mainly find that patients having severe exacerbations of their COPD or asthma, glucocorticoids like dexamethasone or prednisone are going to be most useful for helping to deal with suppressing that inflammation causing that attack in the first place. So you can find these inhalational medications will come either as metered dose inhalers, can come as nebulizer solutions, or as a dry powder inhaler. Sometimes that is abbreviated as a DPI. And basically, these are all ways to get drugs usually through the mouth, down into the lungs there. And so anytime you see, especially something coming from a meter dose inhaler that is more than one puff, you want to make sure you give it at least a minute. I'd probably say at least 30 seconds to a minute between puffs. And this gives it a chance for it to work a little bit better. Basically, by the time the patient has the first dose in, that's helping to kind of loosen that smooth muscle up. And it allows for the second dose to get that much deeper and to work that much better. So I kind of say to patients, hey, if you paid a lot of money for that drug, if you want it to work better, make sure you give it a little bit of time, and that will help it to work that much better there. Okay. If a patient's using an inhaled steroid, which I'll go over that list in a moment here, you want to make sure they rinse their mouth out afterwards, mainly because if they don't, you can end up seeing what they call thrush, which is a candida infection, or basically it's a fungal infection. You can have due to the fact that the steroids will cause sort of a local immunosuppression in the back of the throat, and that can lead to the candida to start to grow, and that will cause that thrush. And you'll see that as a bunch of kind of white plaques in the back of the throat. And so not a great thing. You have to treat it with oral antifungals, and you want to avoid that if you can. Okay. And make sure to educate it's really important that you educate on proper use of things like nebulizers and inhalers, because if they're using it improperly, the drug is basically not going to get down into the lungs where it's needed, and it's not going to be all that effective. Now, some of the common drugs we're going to use here include our short-acting beta agonists. So albuterol is by far and away the number one agent you're going to see here. Definitely first in terms of just order of use, used most commonly for short-acting beta agonists, short-acting rescue inhalers. And then some patients will develop a lot of side effects from albuterol, so they may use something called levalbuterol or Xopenex as an alternative. And then we have long-acting beta-2 agonists will basically kind of work throughout the day in order to prevent symptoms from occurring. And so that'll include things like salmeterol and formoterol. We also have glucocorticoids, and these are really good for help treating prolonged symptoms of asthma and help preventing attacks from occurring. And this includes things like budesonide, fluticasone, and mometasone. You'll note here that there's a lot of varieties that are very similar to your the nasal corticosteroids. So you want to make sure not to mix up the names here, because patients will basically or potentially, say pharmacy tax or something like that in the hospital can fill the wrong one. So, for instance, the brand name for the inhaled fluticasone is Flovent versus the nasal form is Flonase. And so because they sound so similar, it's very easy for them to mix the two up there, and you want to be careful with that. For more severe exacerbations, say a patient's having an acute asthma attack, they require going into the hospital. This is where our systemic corticosteroids come into play here, things like dexamethasone, prednisolone, or prednisone. Now, certainly some other prophylactic medications you can use to try to prevent attacks from occurring include things like leukotriene antagonists. Basically, leukotrienes are another inflammatory molecule that cause bronchoconstriction to occur, and so the most common one here is going to be montelukast or Singulair. Now, this is important to take it at nighttime because you're going to find this is where leukotriene production is actually going to be highest at night, and that's why a lot of people have asthma symptoms in the middle of the night, is because of the fact they're producing more of those leukotrienes. So montelukast is good to take at that point. And then for really severe cases, if patients need some extra help in order to help control their asthma symptoms, they'll actually be put on a drug that binds up IgE, which is one of the major mediators that causes asthma. And so this is a very expensive drug that has to be given via injection only. It can cause anaphylaxis, so you have to be really careful with this one. Because it has a lot more risk with it, even though it's so effective. Some patients have to weigh the risk versus benefits to see if it's right for them. And actually, asthma and COPD get treated pretty similar to one another because a lot of it has to do with inflammation. Obviously, the causes for the disease are quite different. Asthma being sort of a more of a genetic predisposition to allergy and things like that. COPD more oftentimes related to smoking, not always, but is quite frequently the case there. And so again, they'll also use things like short-acting beta agonists as a means of causing relaxation of the bronchial smooth muscle. And again, those are nice because they don't really cause a ton of systemic side effects. And you'll see long-acting drugs being used for them as well. And if they're having an acute exacerbation, again, glucocorticoids are good for a short course, usually like 5 days or so. We have some medications that can be used to treat influenza, and this is topical because we're actually getting into the flu season. So hopefully most of you have already gotten your flu shot. If not, I would strongly consider it in order to protect yourself and potentially people you may be running into. I won't talk specifically about the flu vaccine here, but 2 drugs we'll mention that can be actually used to treat the flu include zanamivir and then oseltamivir. This is far and away the more common one I end up using quite frequently. This is Relenza is actually an inhaler, but we use Tamiflu all the time, especially in the peds ER. Kids are coming in for upper respiratory tract infection, test them for the flu, and sure enough, we'll go ahead and give them some oseltamivir for that infection. A really important point to note with the influenza medications here is that you have to use it within 2 days of onset of symptoms. That's when they're going to be most effective. Basically, they won't get rid of the disease entirely, but they do shorten the course, so that way patients are symptomatic for a shorter period of time, and maybe can help to prevent overall severity of disease. So this is a really big thing here. Usually within 48 hours of symptom onset is when we're going to be cutting that off. So if a patient shows up and they said they're having symptoms for 3 days and they test flu A positive, we'll not give them Tamiflu because of the fact that basically it's not going to be that effective. The one exception to that would be if you have say someone less than 1 year of age, or say they're quite elderly and they're coming into the hospital, they may still benefit. So we'll go ahead and give it to them in those cases. But run-of-the-mill influenza, 48 hours is sort of our cutoff point. Now, another infection you might see occasionally, especially in neonates, and again, kids that are less than 1 month of age, is what we call RSV, or Respiratory Syncytial Virus. And this can be potentially deadly in very young patients. That's where you see the most commonly. But certainly other patients who maybe have immune system diseases or they have cardiac disease may be more at risk as well. And basically what we can do is give them an antibody called palivizumab or Synagis, and that will actually help to prevent them from developing an infection in the first place. So one drug we can use for that. And that's it for respiratory disorders. If you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.